day of lunch. If you're after lunch, I have to keep you awake. So we'll see how we do. Briefly about the Institute for Healthcare Optimization. We are a nonprofit organization based outside of Boston in Massachusetts with a threefold mission. One is to do teaching and research in the area of the science of operations management in healthcare delivery. But more importantly, is our mission to help healthcare systems to optimize their operations so as to improve quality, safety, efficiency, and value as the term of the day now. Our contribution to this field has been the introduction of a methodology to understand and reduce and manage variability within healthcare operations within a clinical enterprise, as opposed to the global sort of variation that we talk and hear a lot about, variation in population outcomes across systems or across geographies. All over the world, healthcare is affected by a number of very difficult challenges. We have overcrowded facilities, staff shortages, financial constraints which do not allow us to invest more than we have already, clinical burnout, where clinicians are facing peaks in patient demand and barely keeping up with the work that is demanded of them. We're continuing to be challenged in terms of quality and safety performance, and to top it all, we have to deal with patients who are often not as happy as we would like them to be, despite our best efforts. The reasons for a lot of these challenges are manifold. You have an aging population all over the world. You have medical advances that are making it possible to treat more and more conditions and allow for management of care along a longer period of time as patients continue from an acute episode into a sort of chronic management of illness. In some parts of the world, as incomes grow, healthcare becomes more affordable and more people are hoping to receive care, and that is increasing demand there. And all over the world, you have a problem of chronic diseases as patients are dealing with multiple comorbidities and so on. But the one challenge that, or a reason that we do not talk as much about is the variability in clinical operations, and that is where we will focus for the next hour or so, or certainly the first 30 minutes, and I'm sure Andrea and Jamieson will talk about that as well. Some of the key takeaways that I hope for you to walk away with are that variability in patient flow is a root cause of many of the quality and safety problems that we encounter today. The second takeaway that I'd like you to remember is that a lot of this variability is not driven just by patient clinical need or for the benefit of patient outcomes. A lot of this variability is introduced by us as healthcare providers, and that is what we call artificial variability. And the last point I would like for you to remember is that this variability can and has been dealt with in many healthcare systems across the world, small and large, and I will share a few examples with you. So we will spend a few minutes at first looking at some of the theoretical underpinnings of our work, and then more time really looking at some of the examples of outcomes from various hospitals and health systems. In an ideal healthcare environment, all patients have the same disease. They recover from treatment or with treatment in about the same amount of time in the same manner. And also, all clinicians have the same skill and training to provide care. And lastly, patients arrive uniformly over time, every 15 minutes, not every 4 minutes or 3 minutes or 12 minutes or a time of their choosing, but every 15 minutes. That would be ideal. Such a healthcare environment would be easy to design for in a way that ensures the highest quality of care and the lowest cost possible. But this ideal doesn't exist. What we have instead is that patients have very different diseases when they come to us. What we have is variability across providers in providing treatment to those patients. And what we have instead is patients arriving at whenever they need care rather than every 15 minutes or some arbitrary fixed amount of time. Take a look at these very simplified examples. In this scenario, you have, and these two examples show you sort of a demand and capacity matching or a mismatch situation. In this scenario, you have a demand as presented by those round balls, and the pipe represents your capacity. Again, bear with me, this is highly simplified, but hopefully it'll make sense in a minute. Or you have this scenario where demand arrives in a smoother fashion, and you have a certain capacity to provide care for that demand. It's the same demand, but it can arrive in two different ways. I would think most of you would agree that the second, the lower scenario, is one that would be more appealing to you in a way that you can manage to provide that kind of care. However, what we are presented with often is the first scenario, the one on top. What that means is if you design for average capacity, and how many of us designed for capacity to be at an average level? We do. That is a common way to design how many beds you need, how many staff you need, and so on. What happens is if you have an average size pipe in the first scenario, you will either experience that some of this demand has to be rejected or sent away, or has to be delayed, or you have to have a bigger pipe. Or in other words, you have to have more capacity for the same demand in order to accommodate those peaks in a timely manner. So variability basically increases the possibility of rejection. It necessitates greater capacity for the same demand. It also leads to overcrowding because we are not always able to delay and smooth out the flow as it arrives. And finally, those peaks lead to clinician burnout, one of the very issues that is central to quality and safety of care. Now, this is not just a simplified example. Let's take a look very quickly at what happens in healthcare when we have variability. I'm going to share a number of studies very quickly. I do not expect you to get into the details of these studies at this point. You'll have the slides later, and all of the references are at the bottoms of those slides, so you're welcome to look at these. And also, these are just a few of the studies that I want to show you as an example, not really to say that this is the exact study that you should be paying attention to. So here's one of many studies that looked at high occupancy and peaks and associated that with increase in mortality in Denmark. Here's another study that looked at the number of patients admitted or seeking admission electively to the ICU. That's the blue line. And the white line, which seems, I think you will agree, highly correlated, is the number of patients rejected from that same ICU when there were peaks in elective admissions. So the number of elective admissions is driving out other patients who also need admission to that ICU. When you have such peaks, what we tend to do is place patients in some other ward, what is likely a suboptimal or an off-service ward. Some of you may call this boarding. When we do that, there is evidence that shows that patients who are placed in inappropriate or suboptimal wards experience greater risk of error, and in this case, it led to the death of this young man, who was placed in a cancer ward after surgery that had nothing to do with cancer in this case. Even short-term peaks lead to an increase in mortality. What this study found was every nursing shift, and a nursing shift defined as an 8-hour shift per day, every nursing shift that a patient is exposed to when there isn't enough capacity or there isn't enough staff or the staff are overloaded leads to a 2% increase in the mortality risk for that patient. So if you were to imagine an average patient stays in your hospital for, let's say, 5 days, and let's say 1 out of the 3 shifts during that day, that patient is exposed to an increased risk of mortality, you're looking at a 10% increase in risk of mortality for that patient, 2% for every shift on each of those 5 days. Variability has been shown to increase the risk of readmission. Out of this study that came out of Johns Hopkins, they looked at the neuro ICU and found that when you have peaks in admission, what you tend to do, and we all tend to do this, is to expedite transfer out or discharge of patients. There's lots of patients coming in, so one of the ways to deal with that is to see who's maybe close enough to be ready to leave the ICU. So you move them out. What they found is there's a 500% increase in the risk of readmission for those patients. Peaks are also have also been known to increase the risk of the use of rapid response teams, or some of you may call them medical emergency teams. And this happens when patients aren't able to be placed in appropriate levels of care, thereby necessitating the launch of a rapid response team to protect them when they deteriorate. And lastly, peaks increase the risk of medical error. Again, there's several other studies other than the ones that I shared with you, but all of them basically make the point that these peaks and variability increase several risks that we are imposing on our patients. So patient flow variability is increasing overcrowding, increases delays, it increases boarding, that is placement of patients on inappropriate wards, it increases mortality risk, readmission risk, rapid response teams, increases medical errors, and it potentially increases clinical burnout. What the science of operations management tells us, though, is that managing this variability in patient flow is absolutely central to creating a foundation or a foundation to build the architecture for high quality and safe care. What I will submit to you is that no matter what else we do to improve quality and safety, and there are many things that we are doing every day and are absolutely appropriate, but no matter what else we do, as long as we allow this variability to continue, we will not fully solve these problems. We will continue to have many of these problems, or at least some of these problems, on an ongoing basis. In order to begin to improve on variability, here's a critical distinction that we need to make. It is the different types of variability that we are experiencing in healthcare. The first is what we call natural variability. This is a result of naturally driven processes. It is driven by patients' clinical need. It is driven by what makes sense and makes care better for patients. And don't you know it, it is also statistically predictable, which allows you to use scientific methods to design your operations. On the other hand, you have artificial variability, which is a function of man-made decisions. It is not statistically predictable, and it is not driven by the patient need or for the benefit of patient care. Natural variability examples are as follows. When patients arrive to your emergency department, largely the arrival patterns, and I'll say largely, not entirely, but largely those arrival patterns are naturally variable. Another example is that one patient takes 3 days to recover from treatment for a certain condition. A different patient may need 4 days or 5 days. Most of the time, that difference in length of stay or the amount of time they need to recover is not driven by us, but is driven by the patient's own condition and their own ability, or not ability, but their own recovery from the disease. That is natural variability. But we're going to focus on artificial variability, and let me share a few examples of those with you. The first is an area that we use in many parts of our system, which is where we use criteria to determine who should receive care in what location, or which patient should be prioritized over which other patient. So these criteria that determine the level of care, or determine where a patient should go after hospitalization, or they determine which patient should have surgery before which other patient. Those types of criteria, wherever those exist or do not exist, is an opportunity for artificial variability to come in. Another area where we see a lot of artificial variability is wherever you have scheduled flow. Wherever you schedule patients for care a few days or a few weeks out, that is a clear place where you will see a lot of artificial variability. And we wouldn't think that that is the case because we schedule our operating room sessions or your clinic sessions and so on. However, in fact, when you go in and look at the number of patients scheduled from day to day or from week to week, you will find that there is tremendous variation which we are imposing on ourselves. And the last bit is process and capacity. Everywhere we batch our processes, especially when it relates to unscheduled patients, that kind of batching is usually not for the benefit of the patients. It's usually for the benefit of our own workflow. And that is a place where artificial variability creeps in, and it actually hurts patients. Another area is when we have reduced services on nights or on weekends. That makes sense. That happens everywhere, in every hospital and every clinic. but that reduction in service is sometimes to the detriment of patients, and they pay the price, and our system pays a price. And I will share a little bit more about each of these with you in a minute. So enough about theory. Let's look at some of the specific things that you can do to mitigate variability. The first set of things that you have to keep in mind is that there are a few key things, and I think you'll hear the same key things addressed everywhere where you talk about improvement. However, what you do need to have is clinician ownership of criteria and guidelines. And what we mean by that is that you cannot impose criteria. You cannot just have the head of a department determine what the criteria are. You need to have clinicians come together and achieve some level of consensus on what they think should be done in different situations, whether it is for prioritization or placement of patients on different inpatient wards and so on. The second thing you need is the organizational will to hold each other accountable. And I'll say hold each other accountable because it's not just about holding clinicians accountable. Clinicians should hold the administrators accountable because you need to have a set of standard operating procedures around staffing, about booking, as well as the clinical guidelines. So we need to hold each other accountable, and there needs to be a will to do that. And the third thing you need is the ability to capture accurate patient-centric data. We collect a lot of data, we have a lot of information. Often it doesn't speak to each other, or the systems don't speak to each other. We don't have what we just need, which are simple things like a prioritization system for surgery. Who's a patient who needs surgery within an hour? Who can wait 2 hours? Who can wait 8 hours? And so on. We don't have clear guidelines on who needs to be in a monitored bed or a step-down bed and so on. There are criteria, they're on a shelf somewhere, but if you look at your practice day to day, what we find is that those criteria are not being followed, which is basically saying that you don't have the criteria. The last piece, and the most important one, is that any of the examples I share with you, you can take from them and learn from them, but you cannot just implement what happened at one hospital or health system and do it at your place, because variability exists everywhere, but it manifests differently. The reasons and the drivers of that variability are different, and until you understand that, you cannot design a system that will work for you rather than what worked elsewhere. Okay, so let's take a couple of examples with each of these. So the first being variability in unscheduled flow. So this mostly speaks to variability in an operating theater, an operating room environment. However, you can take the same ideas to any place where you have both unscheduled and scheduled care. So what happens at the entry point of an operating room environment? What you have is elective patients that are suffering from sort of rescheduling and cancellation, which happens a lot at these hospitals that I will talk to you about in a minute. And on the other hand, you have unscheduled patients who are experiencing delays in access to operating rooms or operating theaters. Once they get into the operating theater, you have another set of challenges. You have cancellation of elective patients because there are too many unscheduled patients on that day, or you have to run into overtime or overruns to accommodate all of the patients that you have on the list on that particular day. In addition to that, there's a lot of chaos in an operating room where you have frequent room changes. And what I mean by that is a patient was scheduled to go into theater 12, but something happened, now they're moving into theater 14. Someone else who was in theater 2 is now in theater 12. All of this creates a lot of chaos for the staff and the equipment that has to be moved around. And lastly, post-operatively, what unscheduled patients experience as a result is extended length of stay because they were not able to access surgery in a timely manner, and they experience increased mortality and morbidity as a result of those initial delays. So what we did in these situations is the following. The first is, again, establishing criteria for prioritizing these patients, and patients were then queued solely based on patient need, which what that means is you decide what is the maximum time that a patient can wait before they will deteriorate clinically. Based on that kind of information, you decide how to queue these patients. So an A patient who can wait only up to 45 minutes, let's say, has to go before a patient who can wait for 2 hours or 4 hours. What we also did then was we separated unscheduled and scheduled capacity in the theater. Again, the same can be done in your outpatient clinics, and we have done that in other instances. And lastly, as I mentioned a minute ago, you have to have adherence to these criteria as well as these standard operating procedures. The outcome of that at a few hospitals was thus. The first is an example from Scotland, NHS Greater Glasgow and Clyde. And at this board, the Glasgow Regional Infirmary was looking at an increase in emergency surgical patients coming into that particular hospital within the board. And as a result, they had to do something about theater access. Once they made the changes that we just talked about, they were able to improve on waiting times and improve compliance for unscheduled patients from 75% to over 95% of the unscheduled patients making it into theater within the times determined by their surgeons and their clinicians. And as a result, they were able to reduce the length of stay as more patients became compliant with the waiting time. Another example is the Mayo Clinic in Florida, where the same work was done. And what they found is that they were able to increase surgical throughput, and in this case, we mean surgical volume or access to surgery by about 4%, while at the same time, as they were increasing their volume, they were able to reduce overtime by 27%, and they were able to reduce the chaos in their operating room by 70% in terms of the number of times that the operating room was changed from what was planned to something else. And lastly, and this is one of the really nice findings here, was that as a result of this reduced chaos, they were able to improve staff satisfaction and reduce turnover by 40%, which not only saved them $1 million, but it clearly improved the quality of care that these staff were providing in their operating rooms. Another hospital here in Canada, in this case, one of the largest, or larger, I will say, academic centers there, the Ottawa Hospital, already one of the lower mortality rate hospitals. What they found is when they did this, they were able to reduce the mortality rate for unscheduled surgical patients from 3.9 to 3%, translating to about 40 lives saved every year. Let's take another area of artificial variability, which is an inpatient level of care. So in this case, I'm sure many of you experience that your hospitals are overcrowded, and you have to do something about the flow from your ED into your inpatient beds and out of those inpatient beds. And this is what we have seen at a number of hospitals. Patients coming in, they often experience waits and delays getting out of the emergency department and getting into whatever inpatient area they need to, unless, of course, they're going home from the emergency department. Once they get to the inpatient beds, they sometimes are put in, again, suboptimal or off-specialty wards where they may not receive exactly the care and exactly the services they need, which may lead to an increased length of stay as well as an increased risk of medical error or misdiagnosis. Finally, a lot of these patients at the back end face delays getting out of the hospital to whatever post-acute facility, such as rehab or nursing care or long-term care that they may need. And all of these bottlenecks sort of continue to sort of make the hospital more and more overcrowded as they go. So what do you need to do there? So the things that we've done are to look at, again, criteria for admission to each type of ward at a hospital. Who needs to be in an ICU or ITU or whatever you call your intensive care wards? Who needs to be in a step-down type of care? Who needs to be on a monitored bed? And who needs to be in a specialty bed as opposed to a generalized, say, medical bed or a geriatric care ward? Again, incorporating these criteria into your daily rounding processes so that they're not part of a project, but they're really business as usual for this hospital that you're working with. And lastly, you then are able to collect data that allows you to do the modeling using sort of queuing and simulation, which I don't have enough time to get into, but you can use those methods to figure out exactly how many beds or how many staff you need at each point of care within your system. An example again from Scotland here, NHS Forth Valley did many of the same things, and what they found in their medical wards, acute medical wards, is that they were able to reduce length of stay by about a day, which resulted in capacity to accommodate about 1,000 patients within the same bed portfolio that they had. So they did not add staff, did not add beds, and yet they were now able to admit 1,000 more patients. As a result, they decrease the waiting time at the inflow point. They decrease the waiting time for patients coming out of their ED and looking for an acute bed. What's not on there, but what I should say is a couple of other things happened. They were moving patients up from their emergency department into their wards earlier in the day, which allowed for a full team to be there to be able to see the patient as they came in, rather than a patient coming into your ward at 8 or 9 or 10 p.m. who doesn't get seen until the following day. What also happened is that the queue of patients waiting to leave the acute hospital for community hospital or post-acute care reduced, because they were able to have clear sense of who needs to be there for what, and those criteria and adhering to those criteria allowed them to send more patients home, reducing the number of patients needing continuing sort of care in a facility. Another example here from the US in this case, a hospital that did this work in their telemetry beds or monitored beds. And what they found was that when they did all of these things, adhered to criteria and so on, they were able to reduce the number of inappropriate admissions to telemetry from 18% to 1%. They decreased ED boarding time, the time that a patient is waiting after they're done with care in the emergency department, from 18 hours to about 9 hours. Length of stay decreased by 31%. They were able to reduce the number of beds by 12, and at the same time, your patient satisfaction actually went up, because the staff were able to now provide appropriate attention to the patients who really needed to be there, and were able to engage with the patients appropriately so that patients felt better cared for. And the third example that I'll leave you with is variability in scheduling and process. What you have here is at the point of entry, we schedule patients, we then have to call them back and reschedule them for a variety of reasons, and often it is because there are no beds available that day or the day after, and so you don't want to bring them in when you can't guarantee that they will have a bed in the appropriate ward. After they experience all of that at the point of entry, they come into the hospital, then they may sometimes still be placed on an inappropriate ward or a specialty that is not appropriate for them and sufficiently geared to care for them. They may have to deal with patients or staff, or staff that have to deal with them may not have enough time for them because they are dealing with the peaks in admission on certain days. And they're then again at risk of increased risk rather of errors or misdiagnosis, just like the example I shared a few minutes ago. And finally, patients who come in at or near the weekend experience delays and prolonged length of stay because we slow down and our service levels are reduced over the weekend. So the changes you have to make here are basically to reduce the variability in the number of patients scheduled from day to day or from week to week. Again, there's a lot of detail that goes in, but that's in essence what was done. And then we also smoothed the resources and processes over the weekend without fully staffing up the weekend. You can still do a number of things to provide appropriate allied health or clinician coverage. Here's an example from a hospital in the US in New Jersey. And what they found is as a result of these changes, they were able to increase surgical volume, provide a smoother nurse staffing level, and as a result, they again experienced increased patient satisfaction with communication from clinical staff. This is a busy chart. What I really want you to focus on is at the bottom. Patients in this orthopedic service that were admitted on Monday experienced a 3.5-day length of stay. These are elective patients. Patients of the same kind admitted on Fridays experienced a 4.37-day length of stay, which is almost 25% higher than patients admitted on Monday. As a result of the work that was done to look at the weekend and clinical coverage, they were able to reduce the length of stay for patients admitted on Thursdays and Fridays down to something similar to what patients admitted on Monday experienced. And here's an example of a medical center that did many of these things around managing artificial variability. And what they found was that they were able to reduce waiting times by, you can see 34% or so. They were able to increase surgical volume by 7% without building operating rooms. In fact, they avoided building a whole new inpatient bed tower of 100 beds that was planned previously once they were able to address variability by treating all of those patients that were coming in and the growing demand that they faced without additional capacity. So again, the key takeaway is that variability is a key cause of quality and safety issues. that a lot of this variability is driven by us, and the good news, which is that it can be addressed, and it has been addressed by a lot of different types of medical centers. I'll leave you with just these additional resources. There's obviously the website of our institute that has a lot of additional information, as well as short video clips that may be useful to you to share with your colleagues. And lastly, there's this book, Optimizing Patient Flow, that is, I think, coming out by the end of this month. It's available for pre-purchase, which gives you a lot of detail on the case studies, as well as the exact sort of details of the methodology that I was able to share with you very, very briefly here. And I think as of next week, some parts of this book are going to be available for preview, and I'd encourage you to take an opportunity to do that.
Sandeep, thank you very much. And it's a huge amount to sort of take away there and to think about. But I think without any more sort of ado, I'd like to introduce two colleagues from Scotland. Helen Maitland was the title of Director of Unscheduled Care for the whole of Scotland. So that includes, I assume, the Outer Hebrides as well as Inner Glasgow. So just think about that. And Andrea Jamieson, who is the National Improvement Advisor for the 6 Essential Actions for Improving Unscheduled Care, again, the national programme for the Scottish Government. Andrea and Helen.
Thank you very much. So the 6 Essential Actions was a national improvement programme that was launched in NHS Scotland in May 2015. It was developed in partnership with the Scottish Academy, the Academy of Royal Colleges, NHS Scotland and the Scottish Government. The group got together and identified what were the known causes of poor performance for unscheduled care in Scotland. We were very clear that the aim was to improve the patient and staff experience of unscheduled care, and we had a ministerial objective to deliver the target, a 95% target, for all patients to be admitted, discharged or transferred from the emergency department within 4 hours. This target is really seen as the barometer of the whole system. The emergency department cannot deliver the target on its own. It requires a whole system resource and a whole system response to ensure that capacity meets demand, not just by the day of the week, but also by the hour of the day. The 6 Essential Actions was brought together to determine what would be the key components that would ensure that the system was working appropriately to deliver that best aim. Prior to this, what we found was that sites worked very much in silos. The medical departments didn't talk to the surgical departments. We had different priorities, and we had different opinions on what was the priority for the patient. We were very clear that when we worked together, the organisation had to come together, and we introduced what we called triumvirate leadership. This team was led by the site director. So we had one person who was in charge of the whole hospital. So there was no competing priorities if there was a surgical waiting time initiative or if there was winter pressures. Everyone worked together to look at what was going to be the best capacity, the best flow for the patient. And taking into consideration the profession and the clinical opinion on what were the priorities was very important. They worked together to introduce improved communication tools. So we have site, hospital and safety huddles every morning to determine what are the pressures in the hospital and what's going to be the appropriate response across the whole system, and not just leave the pressure in the emergency department to cope with patients that are coming. To manage all this, we had to understand what the patient capacity and what the flow was for patients. So we looked at what the system was around the understanding with the basic building blocks. We put a footprint of the hospital and understood where the resources were, where the pressure was in the system, and where things were not aligned appropriately. Where possible, we realigned that to ensure that we reduced unnecessary waits, delays and bottlenecks across the whole system. using modelling and simulation. Understanding the patient journey, rather than just how many beds we had in the system, and to recognise the complexity of the inpatient journey was absolutely crucial. And Andrea will go on to explain that in more detail. Managing the patient's journey through the emergency department was important to see that the patient was seeing the right person at the right place in the right time. This did not always mean the emergency department. With a 4-hour emergency access target, there was some challenge that patients would be admitted inappropriately simply to meet the target. So it was important that we looked at where patients needed to be, and if they needed a longer stay, then where could that be delivered? But this is all aligned across the 7 days. Often services reduced at the weekends and out of hours. I don't know if many of you have left your hospital at 5 o'clock at night, and the traffic jam and the queue is quite impressive trying to get out the hospital. So we know that things do settle down after 5 o'clock, but that's often when patients arrive at the hospital, at the front door, and in most need of attention as our services reduce. So looking at what was appropriate and what was required was understanding the system, the capacity and demand needs over this time. Ultimately, we want to ensure that patients are cared for at home, in their own home, and treated as close to home as possible. If they must be admitted to the emergency department, then let's ensure that we can get them home as soon as possible, and if a stay is necessary, then they go home when they're fit and ready. So what has that looked like for performance? In Scotland, we compare across the 4 nations of the UK, and prior to the improvement programme, we ran a similar line to NHS England, which is the top one. However, since we introduced the programme in May 2015, we saw a divergence of that similar line, and we have been best in class for the UK since then. But we're not out of the woods yet. We have had the worst winter, and despite the winter planning that was put in place, then we have seen resilience and challenges and performance being challenged. We have just before Christmas, we would normally be the time that patients would be discharged for Christmas, but that didn't happen this year. Like many, we were suffered from inclement weather. We had what we call Black Ice Monday, and in that time, there was many admissions for trauma and orthopedics, which coincided with an increase in influenza-like illnesses. And this put demand onto the hospital with increased admissions, increased demand, and increased length of stay. And as that continued over the winter period, over Christmas and New Year, we continued to have further inclement weather. It is Scotland after all. But we were really pushed when we had what we called the beast from the east, which was a prolonged length of stay of bad weather, and so our first red weather warning to remain indoors where possible and not to travel. Despite this, we still had increased demand at the hospital over this period. And with our hospitals already at full demand, this put pressure onto the ED. Each one of these dots on this slide is a patient. And this shows the pattern of demand that happens across our emergency department at the time that they arrive and across the day of the week. Each dot translates in this slide into a line. So the line is the time that they arrive at the hospital, at the emergency department, and the time that they are discharged. And each line, as you can see, represents poor patient experience. The red lines that are here are wait for bed breaches. So all of these patients were waiting to be admitted. And the blue line that you can see there are patients who are unable to get into the ED and are actually waiting for first assessment. So they've been seen, they've been triaged, but their care has not fully started. I'm going to hand over to Andrea, who's going to explain to you what we're doing to improve the patient experience and the flow through the hospital.
Thank you, Helen. As Helen said, my name's Andrea Jamieson. Thank you for choosing to come and listen to us. I hope you're not too into your post-lunch slump. I'm hopeful that you find our presentation interesting, and you'll find our contact details on the last slide if it raises any questions for you. So we've called daily dynamic discharge, which is our approach to essential action 3, which you heard Helen describe, shifting the curve. So I'm going to explain a little bit about what that means to you as we go through this presentation. So let's start with a bit of context. Delay is real and present for every patient who enters into our system. And unfortunately, usually patients suffer from delay from the very first moment that they become unwell. If you're at home and become unwell and seek medical advice, and the doctor who sees you decides that you need to be seen in hospital, you're likely to wait. You're likely to wait to be seen by the doctor and potentially for some transport. If you then come into hospital and wait for some assessment to happen, some diagnostics, you may wait to be seen by a doctor. We may then decide to admit you as an inpatient. You're likely to wait for an assessment bed. So once you're in an assessment bed, we may decide that you need to be admitted to a specialty bed, and you're likely to wait for that bed to become available. And then once you're in that specialty bed, it may be that we decide there are patients who are more in need of that specialty bed than you are, who are sicker, and we may board you out. We may send you to a borrowed bed from somewhere else in the system. If you're in a boarded bed, if you're boarding into a borrowed bed, you're likely to wait. You may wait for the doctors to come and see you. You're definitely likely to wait for the things that you need for discharge, to be discharged home. So delay is real and present. The moral of this story is that it offers us an opportunity for improvement. There's lots of things that we do and don't do in our daily lives which prolong a patient's length of stay. So let's just focus on the first bit of that journey, delays in access to access to a hospital bed. We measure a hospital system's ability to respond to the demand that's placed on it by looking at how many patients are admitted within that 4-hour target that you heard Helen speak about. Now, the target may sit at the front door, but it's actually just a barometer for everything else that happens in the system. It's a very complex health and social care system. And lots of different parts of that system behave in quite different ways. So if you are in an emergency department, the emergency department is likely to work in hours and minutes. And the further away you move from that emergency department, the pace slows down. So in wards, it then becomes days and weeks. And the further away from that out into the community, it may even be weeks and sometimes months. So that also offers us an opportunity for improvement. We really need to start to think about how we improve the throughput from this system and better align demand with capacity. So the NHS Institute for Improvement have described this phenomena that happens in every hospital all over the world, which happens when the total number of new admissions within a hospital environment outstrips the number of discharges and necessitates reactive patient discharge. Now, that's simply one of the ways that hospitals choose to deal with and cope with the imbalance in their system. There are others. So imbalance is hard. It's hard for our patients and it's hard for our staff. If you're a patient in an imbalanced system, you're likely to experience queues, waits for treatment, delays. Actually, sometimes that translates into cancellation of elective procedures. You may not get to the right ward when you need it, and that of course means that you're likely to have a poorer experience, and sometimes we really harm clinical outcomes for patients. And it always increases length of stay if you don't get to the right place at the right time. But for our staff, it's equally hard. It's a great deal of pressure. The sentence in this slide that I kind of giggle at is less than harmonious relationships. If you've ever been in a hospital system that's out of balance in any given day, where there are more admissions than discharges, less than harmonious relationships exist in the extreme. Of course, the combination of that is that we have unhappy patients lots of the time, despite our best efforts. If we're busy and patients are in the wrong places, that can lead to clinical incidents. And quite often, it's hard to work in that environment, so we struggle with staff sickness absence. And of course, that means we have a problem retaining people. So it's a problem. Let's look at it in a little bit more detail. This is one of our hospitals. We have anonymized them. This looks at admission and discharge profile over a month's period. If we looked at that over a longer period of time, it would become a curve. But we want to show you in some level of detail what we're talking about. So the grey bars represent admissions into this system, and the red bars represent discharges. Now, there's clearly an obvious problem. we have the demand for this system appearing much earlier in the day than the capacity is available. The discharges in this system are far later than the admissions. What that leads to is what we affectionately call the window of evil, when all of those things that we speak about in terms of an imbalanced system, reactive discharge, boarding patients into borrowed beds, when all of those things happen because we have a queue of patients and no beds yet to put them into. So the good news is that that offers us a real chance for improvement. But what causes that peak of late discharges? What creates that pattern? Is it patient recovery? Sometimes it is. Sometimes there are patients who have had surgery today and may not be able to go home until later on tonight, and of course tonight is preferable to tomorrow. So sometimes that's necessary, not all of the time, and it doesn't explain away the size of that peak of late in the day discharges. Patient requests, sometimes we may have patients whose family can't collect them until after work is finished, but we have to balance that with the needs of the patients in the queue and whether it's appropriate. Or is it that the staff on these wards are too busy, that other things are more important than discharge, that we have unclear and conflicting priorities, that we don't get the chance to plan well as teams and think through what these patients need for discharge from admission? Of course, the end result of that is if we haven't had the time to plan and discuss what's needed, we're likely to identify the things that are needed late in the day and then probably delay our patients while we're waiting for those things to become available. But what if we could change that? What if we could turn that round and change the discharge pattern so that it was earlier than admissions? Would patients be admitted to the right beds without delay? What if length of stay was only as long as clinically necessary? Would that lead to an improved patient experience and clinical outcomes? And would it be a far nicer place to work? So this is where DDD comes in, daily dynamic discharge. How have we used that to better align demand with capacity within our hospitals? So daily dynamic discharge is an umbrella term, and there's lots of things that sit underneath that. So creating the plan for a patient from admission, as a multidisciplinary team, we come together and think about what does this patient need in order to become well enough to leave our care? Can we draw a line in the sand and start to think about an estimated date of discharge? And let's make sure that we're reviewing that, because patients by their very nature can be unpredictable. Then once we have a plan, how do we execute that plan without delay? How do we make sure that we take care of our clinical responsibilities but also understand the impact on the operational flow of patients by prioritising correctly? So how do we make sure that our ward rounds are done in the order of sick patients first, then discharge priorities, and then anybody else who is staying in the ward? How do we make sure that when we agree these tasks are necessary for today, because otherwise we impact the outcome for our patients, that they happen? And how do we make sure that we check, chase, and challenge and really apply some discipline and rigour to the way that we plan and the way that we undertake the tasks? So that once the patient's clinically and functionally ready for discharge, we can discharge them the minute they're well enough to go, and that should be early in the day. So that's an overview of the process. We've implemented this over the past nearly 3 years over lots of different sites, and they've responded quite differently and taken local ownership of this process. So I'm going to share with you some of the local approaches to implementing daily dynamic discharge. The fundamental structure is the same, but local ownership is key. So one of our sites articulated daily dynamic discharge, and we've been able to explain it from the nurse and doctor's perspective. Now, these slides will all be made available to you. Another site, we're a bit more prescriptive about the difference between morning and afternoon, how those two differ in terms of managing today and planning for tomorrow. Another site went a bit further than that and drew a 24-hour graph to make sure that we understood how the decisions that we make take part of the nursing and clinical handover, and that the activities continue throughout the night and over the weekends, and link in clearly to the site safety and flow huddle. And another site created an A4 piece of paper that they had signed by the lead consultant and were just clear about how they manage today and plan for tomorrow. So in summary, we believe that these ward-based incremental improvements will absolutely aggregate and impact on performance. We're trying to create tomorrow's capacity by planning today, every day. But let's think about some feedback. How has that felt for the staff on the ground? So I haven't got a fetishistic attachment to data, and I really believe that it enriches the story. These are some of the sound bites from the staff that we've worked with and how they felt about implementing daily dynamic discharge. So we're thinking about Monday discharges on a Thursday. We get time to talk to each other about what our patients need. We come into beds on a Monday. The site feels very different, just less chaotic. The one that I laugh about most is the lady who said, I've stopped waking up in the middle of the night. I've been able to not take my notepad to bed with me. So I've been doing this for a while, and I have some reflections if you're going to do something similar. My pro tip number one is make sure that you develop confidence and rigor and discipline through all levels in the ward so it becomes process and not person dependent. We all know when a good senior charge nurse is in that the ward is going to run like clockwork, but how do we make sure that happens when she's on holiday, at the weekends, etc. My pro tip number two is to encourage sites to adopt it and own it. They're more likely to sustain something that they have been fundamental in creating. So the Western General in Edinburgh, instead of daily dynamic discharge, preferred firm, fast and focus. But there were a few iterations before that. My advice is be careful of Fs. Pro tip number three, be patient. Quality improvement is a journey, it's not a destination. This is hard work. If it was easy, we'd all be doing it. So celebrate the small wins and celebrate the small things. So what has it delivered for our sites? Let's look at some site data. So site A, in terms of shifting the curve, we can see that February 17 and February 18, there's been a marked improvement in their discharge pattern by hour of day. Now just think about if you work in a site, how much easier would life be if you had half a dozen beds earlier in the day when your demand hits you? But let's break that down a bit. So pre-noon discharges. February 2017 was sitting at 14%, and by February 2018 it had risen to 26%. So that was an increase of 12%. But let's stretch that out a little bit and look at pre-2 discharges, because we didn't want all of the pie all at once. 29% in February 2017, which rose to 46% in February of 2018. An increase of 17%. Let's take it out a little bit further to 3 p.m. Still make a big difference in your site. 42% in February 2017, and that rose to 60% in February of this year, an increase of 18%. But let's think about what we claimed would happen, that we would aggregate these incremental ward-based improvements in capacity, in-day capacity, creating beds earlier in the day. Has it had an impact on the front door? Let's look at another couple of our sites. So this is site B, and we're looking at the proportion of waits for bed. So breaches for bed, how many patients didn't get into the hospital within that 4-hour period because they were waiting for a bed. So in January 2017, it was almost 40%, but by March of this year, that had dropped to just over 20%. So we're looking at the reasons for breach as a percentage of the total by month, and we're comparing this winter to last winter. So in 2017, 33% of patients didn't get into hospital within 4 hours because they were waiting for a bed, and this year that had dropped to 29%. And actually, against a backdrop of 2018 being a far worse winter. So let's look at another site. So site C, waits for bed were up at 50-odd% last year, and this year it's dropped to just over 30%. Under 30%, sorry. So comparing last winter to this winter, January to March 2017, 52% of breaches were waiting for bed, and this year it dropped to 28%. So significant improvement against the backdrop of that horrendous winter. So we have some key take-home messages for you. Daily dynamic discharge supports Scotland's delivery of the emergency access 4-hour standard. Even if you don't have a 4-hour standard, it's absolutely designed to improve the timeliness and quality of patient care. Now that means timeliness and quality for the patients who are in beds now waiting for things, and timeliness and quality for the patients who are in the queue waiting to access your system. So it's a framework to ensure patient discharges are planned, safe, and as delay-free as possible, removing some of that man-made delay. And it helps teams to really balance their clinical and their operational responsibilities. It's not something complicated, new, or radical, but it is rigorous and disciplined. It ensures that the teams work in a patient-centred way and creates visibility of the queue so teams can respond appropriately. So at a site level, what that means is that we understand our demand pattern by day of the week, by hour of the day, and we can respond and create capacity in the key areas where we need it at the right time of day. And that's because at a ward level, we're managing each patient journey. We're planning from admission to reduce delay and make sure that our patients are discharged without delay on the day of discharge. And for patients who come into our system, what that means is they get into the right bed at the right time, every time. That's our key messages. So we have a Twitter Twitter page. We're happy for you to follow us. And if this presentation raised any questions for you, please get in touch with us. Thank you.
Thanks very much to all three of you. There's two sort of extraordinary sort of talks, a lot of information.